Good afternoon. I'd like to welcome you to today's webinar entitled Active Learning Strategies for the Future of NCLEX, presented by Brent Thompson. My name is Brian Carey, Vice President of Marketing here at Unbound Medicine. In this webinar, we'll be discussing, amongst other things, moving students from passive to active learners, upcoming changes to the NCLEX-RN, and overcoming barriers to curriculum integration. The webinar will be around 30 to 40 minutes, and there will be some time for questions at the end. Please feel free to submit any of the questions in the chat or question areas in your GoToWebinar screen. If we don't get to your questions during the live presentation, Brent will take his time and answer the questions, and we'll reply to everyone via email. Everyone will get the questions and everyone will get the answers to those questions. This webinar is being recorded, and we will send a link to everyone with the full webinar at the conclusion of this event. Now let me take some time to introduce our presenter. Brent was a pediatric nurse since 1980 and earned an MSN from the University of Delaware, and following that a Ph.D. in nursing education from Widener University. He has been active in teaching the use of technology in nursing education for over 20 years and has presented at a number of conferences including the NLN and the STTI. Dr. Thompson recently retired from Westchester University of Pennsylvania as an associate professor after 17 years of service, and currently is a consultant and an advocate for the use of technology to assist nursing educators in active learning strategies in the classroom. At this time, let me welcome Brent Thompson. It's all you, Brent.
Hey, thank you, Brian, and thanks to everyone who signed on today. I hope you get something out of this webinar. Our objectives today, by the end of this session, I hope you can answer these questions. What's the future of the NCLEX-RN exam? You may have heard about some changes coming up. What's the differences between passive and active learning? We'll take a look at some of the things that make it different and how you evaluate students. Third question to answer is, how can we teach clinical judgment in a classroom? And we'll finish up with a short session on what are some of the barriers and facilitators to active learning strategies. So the first question I have for you is to ask yourself is, how do you view nursing and nurses? Are nurses knowledge buckets or knowledge processors? And what I mean by that is, if you are focusing on your education of nursing students as learning a lot of facts and recalling those facts for the exam, then you may be looking at students more as a bucket. But what we're hoping for and what people are moving towards is the view of nursing students and nurses more as knowledge processors. And that is, you focus on analysis of the information that comes in order to make a good decision. You may have heard that the NCLEX-RN exam is changing. If you go to the website that I have listed on the bottom there, the link for the National Council of State Boards of Nursing.org, Next Generation NCLEX, they have a series of FAQs and some handouts that you can find out about what are their plans for changing. Right now, they have been actually for the last several years trying some new style questions for what's called the Next Generation NCLEX-RN, or the NGN. Now these questions are just being tested. They're not necessarily going to be in the exam, but in the end, what they all are trying to do is get a clearer assessment of candidates' abilities to demonstrate clinical judgment as a nurse. Now, clinical judgment is something that we're all familiar with, and we've used different terms over the years, like nursing process has been more commonly used. But really, what we're doing is trying to determine what a client needs through assessment, deciding to act or not to act, and then developing interventions that are either standardized, maybe a modification of standard interventions, or perhaps even new practices. And of course, in the end, everything has to be based on what you expect the patient's outcome to be, how they will respond to those interventions. And that's really a definition that we've been using for many years. Chris Tanner referred to that in 2006. The Next Gen NCLEX exam focuses on clinical judgment, as I mentioned, and they are using a kind of a specific way and some new terminology to describe clinical judgment stages. So the first one is cue recognition, and that's where you analyze the cues. And this is typically where you walk in, you see your patient, you have a history, you know something about him, and then you observe some things. You analyze those cues to see what is going on here. And those cues then are formed into hypotheses. You process that information to form hypotheses. So then you rule some things in and you rule some things out based on the data that as you collect it. And then you prioritize those hypotheses to say what's most important, what do I need to do first? You then have the generation of solutions, which is your planning of interventions. You take those actions and then you evaluate how well did they do? Did I achieve the goals that I was trying to achieve? So we ask, are you ready for the change? And what you have to do is really examine yourself, look at your own teaching methods, and ask yourself, do I mostly lecture? Do I test students for facts, or am I really, or am I testing them for their ability to demonstrate clinical judgment? And we know that it can be difficult to do that. And what are the barriers then? What I want you to do after today's session is think about what are the barriers that keep you from changing your teaching methods. Sometimes people say, well, I ask people, why do you teach the way you do? And here's some of the answers that I've received over the years. One is, that's the way I was taught. Typically in higher education, people teach the way they were taught. You look at any discipline, chemistry, biology, English, literature, the classes generally are taught in the way that those people were taught as undergraduates. Some people tell me, well, that was the way I was told to teach. They may have wanted to try something else, but they come to a new program and they're told this is the way that you must teach. Sometimes people are interested in trying other ways, but they haven't learned them yet, and they'll be interested in learning. They don't know about some of the things that you can do. Of course, a big issue is always having time to make changes. Whenever you want to do something that requires learning something new, you need time to do that. And I know we all have a lot of time constraints in our schedules, and our workloads are already heavy, so that's difficult. Another thing we hear is students need to pass the NCLEX, which is usually, I interpret as meaning we can't change anything because what we have is working. They're passing at 96%. We're getting closer to 100, and so we don't want to change anything. And the final thing is students like lecture, and that a lot of research has shown that over the years, that students really like to have lectures because it's easy, it's efficient, and it's what they're used to. And when sometimes the other thing that happens is you try to ask higher level questions, you try to ask something that requires application or evaluation, and your students complain to you that your question was tricky, it was difficult, that it's subjective, they put that in quotes, that there was no clear answer. Another thing that sometimes happens is you ask students to be prepared for class. You give them readings, you give them assignments and things like that, and you find that a lot of them don't do the work that you ask them to do. And if you do try to press them on it, they complain. You're asking for too much from us. It's too much time. We don't have the time to do that. And so that gets frustrating as an instructor. So we often resort to more traditional ways of teaching. We make a reading assignment, we have them watch perhaps a video ahead of time, and then attend a lecture or watch a video in class. And these are all examples of what's called passive learning. You are often doing something like a lecture. And lectures have been referred to as the sage on the stage. And the sage on the stage, where memorization is most valued. Typically in healthcare education, nursing education, medical education, students' ability to memorize a lot of facts and recall those facts is highly valued. And people really believe that you must memorize lots and lots of information over the years and not think about, well, how do you apply that information? We may talk about it in lecture, but the students often don't get a chance to practice that. And sometimes that practice doesn't come until actually you ask them those higher level questions on the exam. And then we wonder, well, why didn't they do well on our exams? So passive learning, as I mentioned, is mostly watching and listening. And as I also mentioned, it's efficient. It's very, this example today of listening to me on my webinar is mostly passive learning. It's efficient. We can get out, we have lots and lots of people all around the United States and Canada tuning in, listening to this. It's an efficient way to get the information out, but it's not giving me a chance to evaluate your abilities to learn, for me to evaluate what you've learned today. So in that way, it's passive. The focus is on remembering and understanding. And one of the things I always say to people when I talk about this topic is, we pretty much have the same amount of time to teach nursing in our programs as we did for the last 50 years. And yet we all know that there's much more information that's being required of students to learn. You cannot memorize it all. You cannot know everything. You cannot know every detail about every drug. And yet we still focus too much on just remembering and understanding. So what you need to do is look at your test questions and say, okay, these are all good things to ask, but understand that these are lower level questions. So when you're asking somebody just to remember, that would be defining a word, making a list, labeling things, matching, or a little bit higher is understanding, where you ask students to explain, describe, or summarize. Students, as I mentioned, prefer the passive learning strategies. There's lower anxiety with passive. They can come, they sit down, they maybe not even be fully awake. If you've had those early morning classes, they're sitting there slumped in their chair. They're not really highly engaged. They're just trying to absorb the information. And when you try to ask students to answer questions, if your classes are like mine, I have the same 5 or 6 students that seem to answer the questions. And it's very hard to get the whole class to participate. And when you ask students, well, why don't you participate? Common response is, I don't want to look stupid. And as I mentioned, the other problem is unless you build in time for them to apply the application, apply the concepts that you're trying to teach, you cannot be sure that they are learning it. So we've been talking about passive learning. Obviously, then the next step, the way you can demonstrate learning is through active learning strategies. And these are the strategies then that we as teachers use to help our learners process the information to get to that to get closer to clinical judgment demonstration. One of the keys of active learning is it is interactive. So students and teachers need to be interacting, need to be communicating continuously, not just sitting, the student is not just sitting and listening. And the other part of the interaction is student-to-student interaction. So the students are going to be in groups, they're going to be talking things out, working things out, and making short presentations to each other or to the group about what they've decided, and then that can be evaluated. So the focus is on applying, analysis, and evaluating. So higher level active learning levels of questioning are going to be things like where you ask students to solve a problem, to calculate an answer, to analyze by comparing or classifying concepts or situations, and evaluating, doing critique, reframing, or supporting the answers that they provide. We learn by doing. That sometimes seems so obvious. We have simulation labs that really demonstrate this to us, and yet very often in the classroom we don't ask students to do this. You learn what you learn by doing. What you learn by doing is more likely to stick in your brain. And you probably all had the experience as nursing students when you took pharmacology. It all seemed the same. All the drugs seem about the same, and it's hard to distinguish the differences between them. But when you got your clinical assignment and you got your patients with that list of drugs, and you started to figure out, oh, this is why they're getting that, and this is why they're getting this, suddenly that drug made a lot more sense, and you remembered it. That's this idea that learning by doing sticks. So what are some things that you can do to demonstrate active learning? Well, these are 7 major techniques and strategies that are being used. I'm just going to talk about the ones at the bottom there. The flipped classroom, the student created wikis, and the case studies in blue. But before I move to those, I just want to mention simulation, which most of our nursing schools nowadays have simulation labs. They focus a lot on good task performance. They work with a lot on communication, making decisions clinically, and so they really are good active learning strategies. Games are something that a lot of people like, Jeopardy games and things like that. I'll give you one caveat on games though, and that is, ask yourself, if you're doing a game, you're spending a lot of time preparing a Jeopardy game, is it really helping the students learn or demonstrate clinical judgment, or is it helping them just recall information that you wanted them to learn? So games have what's called the novelty effect. Students like them, they're fun, but they often don't really help students get to a higher level learning. Role playing, which is very exciting, difficult to do, really good for psychosocial concepts and communication. Concept maps are also very good because a lot of you may be using these in the clinical area, where you have your students look at the concepts, the nursing issues, the medications, the pathophysiology, and bring them all together into a form on paper, so that they can demonstrate what their understanding of how things connect. That's a higher level demonstration of learning. So let's talk about how you decide, before I move into those strategies, how you decide what to use. So I really don't like people just to do things for the sake of doing them, or because it's cool or somebody said I should. You have to think about, really, am I really ready to do this, and why am I doing it? So understand that active strategies take a big time commitment. You have to do a lot of preparation. It's interesting that in a lot of things like the flipped classroom, students will complain that the teacher did no work. They think that they were doing all the work, and they have no idea of all the preparation that it takes to make one of these, like a flipped classroom, actually work. Students' willingness and ability to prepare. A lot of the research on the flipped classroom, for example, is showing that students complain. They like the learning, but they complain about the amount of time that it takes. As I mentioned, students are used to lecture. They expect that. They don't like to have to do a lot of time preparing. And a lot of them will say, well, you should be able to teach me in the let's say 3 hours a week that we have this class, for 4 or 5 hours a week, and that they shouldn't have to do a lot of outside preparation. Of course, we all know as nurses and nursing instructors that that's not true, but a lot of students really will complain. And then, of course, I think the most critical question to always ask yourself is this improving clinical judgment? Is it getting to show something that the students can do to show me that they are learning? And then, of course, another big question is, how do I evaluate that learning if I use these methods. So some of the issues, as I alluded to, it requires a lot of faculty preparation, requires a lot of student preparation. So they have to know this going in, that there's a lot of expectations of them right from the beginning. It's really important to make your expectations clear to the students. It is harder to evaluate learning if you're used to just using a little bubble sheet Scantron, a multiple choice test, select the one right answer. It's very hard to do that in active learning strategies. And students are conditioned to those passive methods, and so there can be some pushback and a lot of complaints about these methods. And the other thing is, you have to trust your students to do the work. You have to give them the tools that they need, trust them to do it, trust them to make those decisions, and students have to work and trust each other. And sometimes that can be difficult to achieve. The flipped classroom is probably one of the most common active strategy that you'll see in the literature nowadays. Uh, Students are in a flipped classroom. Students will watch a lecture and do a preparation before class. So the 2-hour lecture that you may have done before, you record it and you put it online. You have the students watch it ahead of time and then come to class to do the work. So a lot of students will say, well, you're asking me to do double the work because I'm attending the lecture and now I'm going to it for 2 hours and now I have to come and attend the class for 2 hours. So as the teacher, then you have them do work that's based on the content. You give them questions for discussion. You can put them into groups, and the students can then present their findings. Another thing you can try, it's kind of fun, is student-created wikis. If you're familiar with Wikipedia, that's online. That's where all the users contribute to a topic. So saw the First Man movie the other day, and I wanted to read about Apollo 11. Well, you search Apollo 11, and you see that hundreds of people over the last few years have contributed to the wiki, included history information and news reports and things like that. Well, we can do the same thing in nursing. You can give students a topic, let's say, hypoglycemia. You give them a concept like a nursing theory. You give them a case, and you have them then create as a group a wiki. And there's free tools out there. I think there's one called wikispaces.com that I've used. And you're asking students then to collaborate on their answers to the case that you've presented. So you can give them a care plan that they have to create. One example that I've seen is you give the groups in the class a different nursing theorist and have them each contribute to the wiki about that theorist. And then the other neat thing is that all the students then are also can read what the other students have written. You can refine it. You can have debates about who's right or what's better to include. And then the whole class can then learn from what the other students have learned. Another example you can use is to create some kind of ethical issue and have them discuss how a nurse should respond in that issue. One of my favorites is the case study, and that's where you give students a patient situation, have them identify what's most important, prioritize the care, propose some actions, and what they expect the outcomes to be. They're doing everything that they would do clinically except actually perform the interventions. And as you can see, that's also following the clinical judgment steps that I showed you in the earlier slide. So I'll give you a little case study example here. This is a school nurse situation where you have a 13-year-old type 1 diabetic. He's been diabetic for the last 7 years. He's been giving himself insulin. He tracks his diet pretty well. At this age, his parents know and understand his care, but Jacob mostly takes care of himself. He's a good kid, happy, plays video games, has good grades. comes into your office at 10:30, says he has an upset stomach, he's tired, he's thirsty. He thinks he gave himself insulin, but he's not sure. Said he had a large bagel at 7:30. You know that bagels have about 60 grams of carbohydrates. You assess him, you find he has a heart rate of 110, blood pressure 98/50, lungs 20. You check his blood glucose, find it's 400. You see his school record that he's 60 inches tall, 95 pounds. He has insulin order, and you show him, and you give the students the preprandial glucose minus 200 divided by 40, and then you add that the carbs eaten. He takes 10 units of insulin glargine at bedtime and reports that he did take it last night. So you give this to the students, and typically you would do this after you've then shown them a class online about diabetes, or you can do this as part of a lecture that you give on diabetes, and then you give the students then a chance to decide what to do. So here are some questions that you would ask, what's the relevant data? So you have to pick through, you're asking students then to look for those cues, find out what is it about Jacob that's important now and what's not so important. Are there other questions that you would want to ask Jacob? What are there other physical assessments that you might want to take? Big question, what's happening here? And then what would you do next? And what are those priorities? So these, again, are all part of nursing clinical judgment. You can see my questions are actually following clinical judgment. What are your expected outcomes? And what do you prioritize them from short-term to long-term? And you ask students then to give some reasons, give some history. After they've gone through that, you can then get into even deeper questions and start exploring some more tangential questions about the situation. What's his BMI based on his height and weight? Do we need to address that in his longer term care? What's insulin glargine? Why is it used at night? What research has been done on adolescent self-management? This is a big issue. There's a lot of ongoing research about it. What about his hemoglobin A1C? Do we know what that is? What should it be? What does that number tell you? Is there other teaching that needs to be done? Now, this seminar has been presented by Unbound Medicine, and I use Unbound Medicine with my students because it gets away from the idea of memorizing facts and help students learn to look things up as they need them. As you probably guessed, Jacob was dealing with hyperglycemia there, and so you can use the tools. Now, in the past, we could have students bring in textbooks, but we have software like Unbound Medicine now where we encourage. What I try to do is to have students demonstrate what they're learning, find the tools, find the information, quickly look it up, and start making some decisions about care. So, for example, there was a slide about hyperglycemia. We can learn more about diabetes care, and students can then start prioritizing some of the nursing issues that surround taking care of somebody with diabetes. Insulin glargine, they can look that up, find out how it sounds, look up some of the names for it. So it makes it easy to find. With the things like the BMI, there's calculators that they can use. So there's lots of tools out there that students can use to help them find the information and then use the information as they need it. That's the key. Learning to use information as you need it. Instead of trying to memorize everything about diabetes, hyperglycemia, insulin glargine, you use it as part of a case study. They learn it, they practice it, they demonstrate it, and they remember it better. And one of my sayings is, it's not that practice makes perfect, but practice makes better. So the more they do this, the better that they will do, the better they'll feel about what they're doing. In our final section today, talking about some of the barriers and facilitators. Yeah, you may have looked at some of the things that I've said today and say, yeah, I'd like to try those, but it's going to be really hard to do. Some things I want you to remember if you're trying to implement these things is, number one, whatever you plan to do has to be coherent with your curriculum. You know, generally your curriculum is going to have some kind of outcome statement like graduates will be knowledge workers, critical thinkers, problem solvers. So if you have a statement like that, make sure that your strategies then are following that. And if you're not using active strategies and you have an outcome like knowledge workers, critical thinkers, problem solvers, you have to ask yourself, what are we doing to achieve that goal? Also understand that not all faculty are going to accept what you've just think the direction you should be going. And so it's real important for you to find allies. Understand there's people who may be very set in their ways, very unwilling to try new things. But you find those people in your group that are willing to change, and that helps. The other thing is come up with an implementation plan. If you're going to be using something like software like Nursing Central or some of the other things that are out there, do we require it? How much does it cost? How will we use it in the classroom? Generally, with any technology purchases that you do, I say you've got to be sure that it's being used. Students generally don't mind buying things for class if they use it. I've seen programs that they assign or require some new, interesting, neat piece of software, and then it's hardly ever used. And the students then complain that they felt like it was a waste of money. So those are the questions to ask yourself when you make the plan. What are the cost concerns? What are the costs to your department, your program, and what are the costs to the students? How will this affect faculty workload? Will we be given the time to create these cases, learn how to implement them, and will we be trusted to make these changes, or will there be mistrust and told, well, that's something you can do on the side, but you still have to do things the old-fashioned way? When it comes to software selection, make sure it's a group decision. Contact any vendors that you're interested in using. Ask them to give you samples, and so that you can practice using them, and keep thinking about how would I integrate this into class, and how do we evaluate their learning if we're going to do this, and I can't use my traditional bubble screens, bubble sheets, how will I evaluate it? That's can be a very tough question to answer. So to summarize our class today, just remember that the next generation of the NCLEX is going to really require more demonstration of clinical judgment than ever before. As nursing faculty, you have to examine your own methods related to clinical judgment. Am I using methods that are really helping students learn and demonstrate clinical judgment? Third is active learning provides clinical judgment practice in a safe environment. As you know from simulation labs, part of the advantage of that is that you can't kill the mannequin. And the same thing in classroom. If you're practicing active learning, if you're practicing clinical judgment in the classroom, it's safe. The students should be made to feel safe, not stupid, and help them feel more confident when they get to the clinical area. And just to reiterate for one last time, any new strategy that you try, you'll have to ask yourself, will it help my students learn clinical judgment? So thanks for your attention today. And I'm going to ask Brian to ask any questions that may have come in during the presentation.
Thank you so much, Brent. We did get a couple of questions, and you alluded to some of these, but maybe you can get into a little bit more depth. One of the questions that came in was, how can we test students about what they've learned when we mostly use multiple choice exams?
Well, that really means that you're going to have to probably use methods that are not using the bubble sheet. It means more hand scoring, asking students to write out short answers or short essays, to make priority decisions. You can give them lists of actions and say which are, what's the priority of the actions. So unfortunately, I wish I could say yes, that it's easy to put into the bubble bubble sheet, but unfortunately, it's going to take more work on doing that.
Excellent. And one of the questions came in, what is the biggest required change in terms of students to implement these strategies?
Well, because most of these strategies require students to prepare, that's really the biggest change. A lot of students take pride in not doing the reading, not buying the book, not preparing, and hoping that if they attend the class, they attend the lecture, they can get by with just enough to pass the test. And so you really have to make clear from the very beginning that that's not going to be acceptable, that they're going to have to do a lot more outside work, and they have to know that up front. I think as long as they know what your expectations are, students will be able to follow it, but you can't just spring it on them, halfway through the semester.
Absolutely. And then the last one that I have is, what resources are available to help me learn how to change my teaching other than this webinar?
Well, there's some good books. I can recommend the Teaching and Nursing book. I have a chapter in there, a little plug for myself and the other authors. There's a lot of good nursing education journals to look at, so keep up with the literature. Put in some of the key terms that we've learned today about with some of these active learning strategies like the flipped classroom and the Wiki, and you can see what new resources are there. I also recommend attending some of the conferences that are put on by the National League for Nursing and Sigma Theta Tau have some great conferences that lately have been putting on lots of good seminars on using some of these strategies.
That's fantastic. All right. Well, thank you so much, Brent. You can head on to go to the last slide. I'd like to thank everyone for coming out today, taking time out of your busy schedules to listen to this. We hope that you got a lot out of it. If anyone's interested in more on how Nursing Central can play a key role in your active learning strategies, please email us at sales@unboundmedicine.com. We appreciate it. And everyone, again, will be getting a recording of this webinar. So thanks again, and have a great day.